We want to be able to post it. We'll post this on our social profiles. So if you have to jump out or miss it or want to go back and listen, then you can do all of those things. Highly encourage you and invite you to put in the chat any questions you have. With Zoom, you can send that to the group or you can send it to one of us specifically. And we're happy to address all of those. Super excited to do that. But why don't we introduce ourselves? Dr. Lynn, do you want to start? And then Dr. McKean?
Sure. So I'm Dr. Becky Lynn. I am a gynecologist, and I'm also North American Menopause Society certified. So that means I had to go and do extra training on menopause, both hormones, but also prevention for women in menopause. And I love taking care of women in this time frame because there's so many things we can do to make sure that you feel good and that you are going forward with all the tools you need to be healthy. So yeah, we're in Creve Coeur, Evora Women's Health, and I'll put our website in the chat.
Thanks, Dr. Lynn.
All right, I'm Dr. Melanie McKean. I am a reproductive psychiatrist. I have a private practice out in Chesterfield, but I see folks both in person and virtually. So I see everything that runs the gamut, mood and anxiety-wise, interwoven with reproductive health. So that could be anything from mood and anxiety symptoms related to menstrual periods, both like at the onset, throughout life, or certainly kind of perimenopausal has been the big area where a lot of my folks are evolving into right now. And then I also see infertility, miscarriage, pregnancy, postpartum, pelvic pain, female cancers, runs the gamut. So I am delighted to be doing this again with Dr. Lynn and Dr. Loden because we all learn from each other a lot with doing this. And I have seen my practice evolve into this area, and it's such a hot topic. So yeah, thanks for everybody for coming and look forward to the conversation today.
Thanks, Dr. McKean. And I'm Dr. Amy Loden. I am an internal medicine doctor by background. I also am board certified in obesity medicine, lifestyle medicine, some training in functional medicine. Couldn't make up my mind, so also did menopausal medicine, right? And so evolving as a human and as a doctor, but really interested in how do we get to the underlying problems that drive diseases and how do we reverse those diseases to the degree we can. So excited for where we're going to go forward here. One of the invitations I'll repeat is please put your questions in the chat so that we can make sure this is of value to you, and feel free to add multiple questions as they come up. What I want to start with right now is I'm going to invite Dr. Lynn, if you would tell us from your perspective as a gynecologist, what is one of the most common mistaken conceptions, if you will, about vaginal dryness and how women have to live with it or not live with it during the perimenopausal years versus menopause? And can you just give us some insight on what that looks like? Does sex have to hurt?
So definitely doesn't have to hurt. So there are changes to the vagina that happen as your estrogen levels decline. So premenopausally, the vaginal tissue is thick, it's moist, it's got collagen and elastin, which makes it stretchy, so sex doesn't hurt. It's got a whole bunch of cells that make plenty of lubrication for sex. And as estrogen levels decline, that tissue becomes thin and dry. It doesn't stretch. It doesn't have as much blood flowing to it. Sex can be painful, or it could be like, I just don't even feel anything. And this is a symptom of menopause that gets worse over time. So many times things like hot flashes, you get them for a couple of years before your periods stop, a couple of years after, and then for most people, they go away. Vaginal dryness tends to show up about 5 years post-menopause and tends to get worse over time. But with that said, even in your 40s, before your periods stop, you can definitely have vaginal dryness. And when it comes to that misconception, if you go to your practitioner and they look at the vagina and you say, I have vaginal dryness, I just don't lubricate as well, their answer might be, well, it looks normal, you don't need anything. Total misconception. If you're feeling vaginal dryness, even if you're still having periods, you can use a low-dose vaginal estrogen. And low-dose vaginal estrogen is like the fountain of youth for the vagina. It restores collagen and elastin, it improves blood flow, it grows the cells that make lubrication, so you grow more of those, so sex can be pleasurable, not just not painful. So I would say when you ask, what is that biggest misconception, is that if you're still having periods, you can't be treated. absolutely wrong. And with that said, one more thing is that, if you see a practitioner and they say, oh, here's your Crisco, here's your coconut oil. It's not wrong to use those. Those are real moisturizers. They do not do the same thing as vaginal estrogen. They're not going to restore collagen. They're not going to restore elasticity, and they're not going to help the vagina lubricate itself. So, yep.
Perfect. And I just have to say, I love your energy level. Like, I don't know how you have this much energy, but I need some of it. So thank you for being so fun and energetic, especially when talking about such a topic that no one ever wants to talk about out loud. So thank you. One of the things I run into in my practice as an internal medicine doctor is that women won't take vaginal estrogen for fear of breast cancer. So just to kind of finish that out, do you want to comment on that at all?
Yeah, so it does not cause breast cancer, not in the least bit. Now, with that said, when you go to the pharmacy and you pick up your vaginal estrogen, if you open the package insert, it will scare you half to death, and you will think your doctor was crazy for prescribing this, because it says, don't use it for breast cancer, concern for stroke, dementia, heart attack. None of that is true. So then you might say, why is it in the package insert? And the reason it's in the package insert is because the FDA mandates class labeling, meaning every single estrogen product, no matter what, if it's vaginal or oral or patch or what, has to be labeled the same. And there is a group of practitioners right now who are running an advocacy campaign at the FDA to get this changed. And I'm so proud of them. Some of them are my colleagues in the menopause space. Because it's preventing women from getting what they need because they're scared. They think they're going to get breast cancer. And that is absolutely not true. And for the one question that I see in the chat for vaginal dryness, do I prefer tabs or creams? My two of choice, I like Imvexy. I'm using brand names here. It's a little pink gel capsule you pop in the vagina with your finger. My thought is it's the least messy, the easiest to use. It's not covered by everybody's insurance. So if you want to go with something that's covered by your insurance, I think the creams are awesome too. I think they work just as well. They're just messier. They kind of leak out more. It's hard to clean the applicator. I tell my patients, put the applicator in the dishwasher. That gets it clean and sterilized. I'm not a huge fan of Vagifem, which is a little tablet that comes with a blue applicator that goes to the top of the vagina. I just feel like it's a raindrop in the ocean. I don't think it does as much as a cream, or Imvexy, which is Imvexxy. Those are my two go-to, but they're not the only ones. There's plenty of other options.
And sometimes insurance mandates what people can use. And so while we want certain things, that may not always be in reach. Awesome. Thank you. So, Dr. McKean, I'm going to pivot to you. And what I'm curious about, I ran into this week actually, lovely lady, perimenopausal years, 40 something. And she talked about how the last 2 weeks before her period, she feels like she absolutely is losing her mind. And she wanted me to test her hormones, and we had a discussion about benefits and risks, et cetera. But what I'm curious about from a psychiatry standpoint is, does this surprise you? And when you hear this, because I can see you already smiling, what do you recommend?
Sure. So, the short answer is no, it doesn't surprise me at all. What I often do is, well, as I said, I treat mood and anxiety for the most part, like leading up to premenstrual dysphoric disorder. So I kind of I usually pull up a diagram of like the menstrual cycle and show them kind of those peaks and valleys of the traditional menstrual cycle, and then how that starts to shift in perimenopause. And then we'll talk through, what were their periods like when they were younger, any mood and anxiety in pregnancy and postpartum, with other times in their life with hormonal shifts. But I have seen that more classic 3 to 5 days with premenstrual dysphoric disorder can lengthen itself out or just be a lot more inconsistent. And that goes right along with the inconsistencies of the hormonal changes that we see when someone's in perimenopause. So, sometimes the things that I prescribe and manage can be very helpful, but if let's say they come to me first, I'm often recommending that they also have a conversation with their gynecologist to talk through, not necessarily checking hormones, because I'm, certainly on that. I kind of explain to them, like, really, unless you're like super far along in this, they're probably just going to be in normal ranges. It's hard to know exactly where you are because it is so inconsistent. So basically they're going to tell you like, yes, you're not necessarily postmenopausal, but it's going to be really difficult to plan for things because they may be so variable. But it may end up needing to be like a collaborative effort between myself and some hormone therapy. But a lot of, people are sometimes scared to take medications that I prescribe, but then they're sometimes even more scared, yes, to take hormone therapy. So,
Yeah.
but if we've tried a few things and it's not working, then I am much more strongly pushing them to meet with their gynecologist. And a lot of the conversations I'm also having with folks that have been with me for a decade or more are, again, the OB-GYN that you are working with to get pregnant and deliver all your babies might not necessarily be the same one that you work with for these next couple of decades. Just have that initial conversation, kind of see where they're at, their amenability to talk to you about these things. And if you're feeling like these concerns are being dismissed, then maybe, I can refer you to somebody that's going to take some of these things more seriously and work together with me to help you manage that.
Can I say one
Great
thing about
perspective.
labs?
Yeah.
We've mentioned it a couple times now about checking labs. And the thing is, for you guys, the estrogen levels fluctuate throughout the day and throughout the month. So they could be 5 this morning and tomorrow evening it's 200. And so people often want their labs and we can draw them. They'll be in the normal range. And but if you feel bad, we treat you.
Yeah.
It doesn't matter what your lab says. You can still feel awful and have normal labs. And that's what happens most of the time. So even if your labs are normal, we don't say, oh, well, your labs are normal, you're fine. No, if you're having symptoms of perimenopause, I'm talking perimenopause right now, you'll have normal labs, then like we treat you, we do something. So like perimenopause and menopause are normal, but suffering is not.
Yes.
And that's what I've advocated for my folks because they've said, oh, they checked my hormones and they were like, well, everything's normal. And I'm like, and that's what I have to keep telling them. Like, if
Big
you're
surprise.
having, and I go, that's why it's not necessarily like, sometimes unfortunately that even like hurts you to maybe if the person that you're meeting with, if your clinician is going to be like, oh, they're normal, so you don't need treatment. Or I've had someone just recently say, well, I talked to my gynecologist about it and they said, oh, you still having regular menstrual periods? Yep. Well, yeah, you're not perimenopausal. And I was like,
Yes.
I'm doing a training right now with Dr. Rachel Rubin and talking all through those things about how, yes, you could have normal menstrual periods all throughout perimenopause. You could, but if you're symptomatic, you should be treated.
100%.
And she piggyback on that vaginal estrogen treatment, because I don't know if the audience is curious about this too, but she was talking a lot about like that movement is also being driven by the fact that it can be really beneficial. It sounds like, again, this isn't my expertise, in preventing urinary tract infections, and urinary tract infections being a leading cause of, medical comorbidity and oftentimes death in especially postmenopausal elderly women. So I didn't know if you guys had anything to comment on with that too.
Yeah, so vaginal estrogen it changes the flora that's in the vagina. When there's vaginal estrogen around, it becomes more lactobacilli dominant. And when there's not estrogen around, it becomes filled with the bacteria that you see in the colon, like E. coli. And that's the #1 cause of bladder infections. So people get treated for bladder infection over and over again, and then they get antibiotic resistance or C. diff and problems with their gut flora when all they needed was vaginal estrogen. I don't know, Amy, if you have anything to add to that.
I do, because this is something that I find shocking to our midlife women and my older women is they recognize the UTI symptoms, the urgency, the frequency, the discomfort, and then they seem surprised that I won't give them an antibiotic when their urine culture is negative. And so it causes a lot of missed opportunity, I think, within the medical profession to tell women, your symptoms are real. You're not crazy. You feel terrible. And there's a different treatment. You don't need an antibiotic. And so I'm a big advocate of anything we can do preventatively. And this is one opportunity that probably is missed quite substantially from women, not just in our perimenopausal transition and early menopausal years, but our 70 and 80-year-old women who, you're right, Dr. McKean, to call this out, because sepsis is a leading cause of death. And sepsis from UTIs is not uncommon as any adult ages, but certainly women aging. So very important. And advocating and saying this doesn't feel right and challenging the status quo is okay, but getting someone to listen to you is not always easy. And so I certainly can appreciate that. I had my child in the emergency room last night trying to talk to them, get them to listen to me as a trained medical professional was tough. So I can only imagine how much more difficult it is in other settings. one thing I also want to just point out through the perimenopausal transition, I hear a lot of women talk about, and this goes back to you, Dr. Lynn. It's not uncommon. Women will come and they'll say, I have breast pain, I have nipple discharge, something's wrong. And October is Breast Cancer Awareness Month, right? And so I think this might be a timely and interesting comment for you, for our listeners, to address this, because they can have their mammogram, they can have the ultrasound, they can have all their labs checked and everything is normal, and they still have breast pain. So for that woman, is there anything that you would recommend for her, since we know connective tissue can be influenced by hormone levels? Would wearing a tighter bra or some other type of stance help? What would you recommend to someone in that stance after they
Yes.
get their screening?
So if they were having breast tenderness and there's no signs of breast cancer on mammogram and they were on hormones and they were having breast tenderness, my go-to is a product called Duavi. I don't know if you use this, Dr.
Nope.
Loden. This is a combination of Premarin, which is estrogen, it's made up of 11 estrogens from horse urine. I know that freaks a lot of people out. It doesn't freak me out. You can't get any more natural than pee. And it doesn't have a progestin in it. It has beta-doxyphene, which is a blocker in the breast. It's a lot like tamoxifen, which is what they give women with breast cancer to prevent breast cancer recurrence. So the beta-doxyphene protects the lining of the uterus from overstimulation of estrogen, but it's also a blocker in the breast. And so I find that this product is a great choice for two people. One, people who are really worried about breast cancer, because you're blocking any hormonal effect on the breast with the beta-doxyphene. But I also use it in people who can't tolerate the progestin or progestogen. So people who get really bad breast tenderness because it blocks the hormonal effects in the breast, or people who get really bad bloating with other progestins, even with progesterone, then Duavi is a great choice. It's an oral estrogen, so it has a little tiny bit higher risk for blood clot than a transdermal like a patch. But still, the risk for blood clot from oral estrogen is so much lower than what your risk for blood clot was when you're pregnant. It's really high. And when you're postpartum, it's even higher. So there's a small increased risk with oral versus transdermal. But if you're choosing wisely and you're at low risk for blood clot anyway, then Duavi is a good choice for those women.
Awesome. Thank you. Dr. McKean, one of the struggles I think all women have faced through their life is the idea of self-esteem and body image. And this is not helped in the perimenopause transition for so many women, whether it's gaining more belly fat, whether it's having skin changes or getting wrinkles. I mean, there's just a lot that goes into it, and it does appear different for every woman. So when you're working with a woman who's in these years of transition, and you're recognizing self-esteem and body image impacting her, how do you help her navigate those challenges?
Well, first, I validate their feelings and their concerns because, it is changing and they're getting very frustrated. And, a lot of the reason why we are doing these talks and these conversations is because not every clinician that you meet with is going to be validating of those sorts of things and taking things seriously and helping. So when they start bringing it up, especially if they don't really have a history of those sorts of things, I mean, there's certainly women that have been dealing with things like eating disorder and body image issues since a young age, or maybe since their like 20s or 30s. But there's some where it is showing up now. Like they were like, up until now, I was pretty confident with myself. Up until now, like I felt good about how I looked. I was happy with my body. And now they were very, very frustrated that like the exercise plan and everything else that they've been doing is nothing's helpful for them anymore. So that's the first thing I do is just like provide that support. And then also, I feel like it's my responsibility to help them to get linked with other people that can help them, because that is where, unfortunately, a lot of things that I prescribe are not helping them to make that any better. And sometimes are even like thwarting some of those efforts. So I just make sure that they have like all of the appropriate information. And then I make sure that I continue to build my network of really careful and thoughtful, responsible clinicians that will help them to navigate some of these things. So like, finding dietitians, finding trainers, finding other people that will work with them and help them adjust and pivot in that portion of their life, but then also referring them back to, primary care and their gyns too to again talk about hormone therapy, because again, that's another one of those signs that like something may be going on, even if they're still having regular menstrual periods and not having hot flashes, because there's still so much misconception that that is what being in perimenopause is irregular menstrual periods and hot flashes and none of these other things, or that they just have to live with it.
Absolutely. It's the unspoken epidemic, right? That we just are going to let women suffer.
Yeah.
In my practice, I see in the perimenopausal years, a lot of women start to notice that their cholesterol panel is changing or that their glucose is going up, and they get very frustrated, especially if they're gaining weight at the same time, how those interplay. And one of the things I want to bring to our audience's attention is there was a massive study that came out about a month ago, and it actually looked at menopausal women and cardiovascular disease risks. Most women are not getting all three of the tests that were done in this study, but I want to bring this to awareness that you can get these tests done. Not every doctor will order them, and the person who's most likely to order them is probably your primary care doctor, but if you don't go in educated and explain to them why you want this, they're probably going to blow it off. The three tests, you're familiar with one of them already. It's your LDL from your cholesterol panel. Second one is a high sensitivity C-reactive protein. We've been checking this in our practice for years, but my impression is that's not what everyone is doing. The third one is one that historically I've checked in very high risk women. And these would be women whose dad died of a massive heart attack when they were 30, or whose grandmother had a stroke when she was 45. Something that is just so far out of normal that we knew that had to be some type of problem. And that is called a lipoprotein. And it's got a little a in parentheses at the end of it. It is a genetic marker and mutation. You can't change it. You don't need it tested every year. You either have this or you don't. But when we check all three of those and they were all three abnormal, women, and the average age of the women in the study was in menopause range, it was around 52. But we were able to predict heart disease and cardiovascular events 30 years in advance. So this is a fantastic way to advocate for yourself from a cholesterol, metabolic, cardiovascular assessment when you go for your next wellness visit. Dr. Lynn, I don't know that you would measure any of those. Am I wrong in saying that that's probably more of a primary care thing?
So I would say those are more of a primary care thing. The one thing that I tend to utilize is the coronary artery calcium scan. Especially in women who want to do hormones, but I'm worried that they've already formed atherosclerotic plaques in the blood vessels. Because when you treat women with hormones, you really want to catch them before those are formed, because hormone therapy can lower the risk that you would form atherosclerotic plaques. But if you have a whole bunch, hormone therapy can disrupt those plaques and lead to a heart attack or stroke. So when I see women, especially if the further away they are from their last menstrual period, and if they have high cholesterol, then I'll often order a coronary artery calcium scan to make sure that their vessels look clean. Now, it can only pick up certain plaques and not all plaques. It's not a perfect test. But I use that to decide if I think that hormone therapy is a safe option for someone. I do get LDL, but if anything's wrong with it, I send them to primary care. Very grateful for what you do and manage high cholesterol and those things.
I love it. I could do it all day long. And so I love the coronary CT scan as well. I will, for our listeners' reference, if you haven't had it, it's often not covered by insurance. Certain hospitals, there's a significant discrepancy in what they will charge you. So before you get it, find out. We send our patients for this regularly, and some hospitals are charging in the thousands and some are charging like $120. So it's a very valuable test, helps risk stratify tremendously. We order it every week as well. That's a great point. Thank you for bringing that out. All right, switching back to sexual health, Dr. Lynn. When you feel gross and your body image is one that we talked about with Dr. McKean, where you're just not feeling your gorgeous self anymore, right? And your significant other wants to be intimate. And that is like the last thing you want to do. There's no libido. You'd rather, I don't know, floss your teeth hanging upside down or something ridiculous, right? What do you tell that woman? Because that's real, right? And intimacy and connection is so important in our life. Where would you go with that?
Yeah. So low libido is so common in your 40s and 50s, and it's such a complex animal, right? Like it has to do with so many things. It can have to do with now you've gained weight and it's around your middle and you don't feel sexy. but also your testosterone levels are declining. They start to go down in your early 30s. It might be because you're having terrible hot flashes, night sweats, you can't sleep, so you feel awful. And by the way, lack of sleep leads to weight gain. So for perimenopausal women, they start feeling horrible. It's a downward spiral of lack of sleep, weight gain, exhausted at the end of the day. And then you might throw in, maybe somebody gave them an antidepressant because they were feeling depressed. Or maybe sometimes people get antidepressants for hot flashes, but then some of the SSRIs, like Dr. McKean knows, like can cause weight gain and low libido. So it's a very complex animal, but like you mentioned, sex is so important to a happy, healthy relationship. It is a mainstay of why we were all still here. And when your sexual health suffers, the relationship suffers, and then it spreads into the family, and it's a big deal. There are a lot of things you can do to improve your sex drive. There are things that are not medicines, and then there are things that are medicines. And when I see a patient, we go through that long list of issues that could be contributing and address them one by one. I'll always ask about painful sex, because in that perimenopause time is when you might have vaginal dryness. And if sex is painful, well, forget about it. That's just good judgment. And one of the sayings I like to say is that in order to want to have sex, it has to be sex worth wanting. So like if it's horrible, a lot of women will end up in the duty sex area. They just want to get it over with. Then it's not good sex. So the next time it's presented, they're like, oh, last time was not good. Why would I want to do that again? And it's this kind of downward spiral. So we really want to make sure that we're doing everything to make sex good. You want to address any other medicines they might be on. You want to address the relationship. You might want to talk about what you can do to feel better about your body, whether that's losing weight or accepting who you are for who you are. Libido is a very complex animal, but there's plenty of things you can do, including testosterone replacement. And then there are also 2 medicines that are FDA approved in premenopausal women for low libido.
Awesome. Thank you. I think the more we can have these very frank, open conversations, not only as physicians, but as women, we are going to be able to help all of us have a better, happier community and family. I'm going to pivot now to a couple of the questions I'm seeing coming up in the chat. I'm going to answer these, and then I'm going to open it up to both of you from your perspectives to answer them as well. So the first one is, can perimenopause affect gut health, specifically around acid reflux? The answer is 100% yes, it can. There's been some really good research studies on this, and certainly if your primary care gynecologist isn't willing to have a discussion about it, then keep looking, because there is someone out there who can help you with this. Second one, from my perspective, is, have you seen migraines resolve in menopausal women? And if you're on a monthly injectable preventative medication, would you advise waiting a period of time after the last period to stop the meds? And so what I see is, it's almost like pregnancy, where it's a third, a third, a third. People get better, people don't change, people get worse. I am super curious what the other 2 physicians here are seeing, but what I generally do is wait and see. And I generally wait 6 months. I can't quote you a study on that. There could be one. And if there is one, then we should go by what the evidence and science says. But generally 6 months is what I would have someone stay on, and then we can see how things go after that. Dr. Lynn or Dr. McKean, do you have anything you want to add to those?
So I would say the gut health and reflux for sure. And I think I heard somebody say once that, like, when you're younger, you can get away with a really bad habit, like really spicy food, lots of alcohol. And it's almost like you're sort of extra, you have superpowers. But then when you get in your 40s, those superpowers go away and it looks like things are really bad, but actually it's normal. The spicy food and the alcohol should hurt your stomach. Not saying that that's what you're doing. But yes, in the perimenopause, like, things kind of catch up and reflux can be bad.
Mm-hmm.
With migraines, I tend to defer to the primary care physician because I don't manage migraines. I do see headaches in women. Some women get menstrual migraines during their period, and headaches do, in some women, not in all women, tend to get worse around menopause. But if they're having serious headaches, I usually defer to primary care.
Fair enough. Dr. McKean?
Well, what I was going to say is first of all, I dropped in the link to the Menopause Society's homepage in the chat for everybody, just as we keep talking about like finding clinicians that are either certified, as Dr. Lynn and Dr. Loden both are, or just interested, which I'm not certified, but I'm listed as one of the ones that are interested. So if you're looking for folks, that's a place to go to search for clinicians, but also to get a lot of information. But, you know, both things that you guys have said, I've definitely seen. So, you know, a lot of women, again, once they get into their 40s and they're not taking hormonal birth control, because again, they've pivoted into that part of their life where they're not having kids anymore, and maybe their spouse has gotten a vasectomy. I just see a lot of things change when they're not on hormonal birth control anymore. And so for a lot of young women in their teens or 20s, they got on hormonal birth control and they stayed on it until they decided to have kids. And then they had all their kids and they were like pregnant and postpartum and pregnant and postpartum. And then they get into their late 30s and 40s. And so that's just one of the things I'll talk through with them is like, well, was there any other time that you didn't have maybe your hormones being kind of managed in some fashion?
Yeah.
And they see a lot of things change. So libido things can change. Headaches can change. The gut health stuff I've definitely seen like evolve also. But for birth control pills, there were a lot of reasons why women took them. It wasn't just for birth control. It was to help manage their mood. It was help to manage heavy, painful periods and menstrual migraine. So all of this, but it's a big theme in my practice right now is being in your 40s and everything that comes with that. And for the vast majority of people, at least seeing me, I have probably a skewed population. You know, again, most of them aren't having their babies, they're raising their babies. They're in like this certain time in their career that can be pretty pivotal because again, you're in your 40s, you're trying to figure out what you're going to be doing. You're in that somewhat sandwich generation where you also have your parents having maybe some of their own issues. And then you sprinkle on top of that all these fun hormonal changes. And so again, a lot of what I do is validate that like, yes, there is a lot going on and so much of it is out of your control. And how do we get a team of people together to help you? Because it isn't just going to be me and it isn't just going to be your gynecologist or some other specialist or even just your therapist. It's going to be a combo for sure.
Yeah, well said. So pivoting a bit, question that we can all three chime in on, I think we've all seen this, is the woman who's in her late 30s, 40s, even early 50s, she's not sleeping well. And for whatever reason, she doesn't want to, can't, isn't interested in hormones. So I want to open up the conversation about what are the non-hormone options, whether they're prescription medications, behaviors, etc. And what are your top 3 tips, if you will? So while I'm letting you think about that, I'll go first. When I see a woman who is struggling with this, the things that come to mind for me are, do you have kids, pets, spouses, whoever in the bedroom who are affecting your quality of sleep? And inevitably, somebody snoring, the kid running down the hallway to go to the bathroom for the 5th time, the pet who needs to jump on the bed and cuddle. Those are all the obvious triggers that we can eliminate. But that's not the common thing, actually, right? For most women, it's that they wake themselves up. It could be hot flashes. It could be getting up to go to the bathroom. It could be that they got 4 hours of sleep and the ticker tape just turns on and they can't turn their mind off. And so a lot of the things we talk about in our practice is what are those other things you can do? So I want to offer a couple of tips. One is that most of us don't realize our bedrooms aren't dark enough, and we think they are. We turn the lights off and they're fairly dark. But the way you can know your bedroom is dark enough is if you hold your hand in front of your face when your lights are off. If you can see your hand, your bedroom is not dark enough. So try that at home tonight and see if your bedroom is dark enough, because if your pituitary gland isn't getting the correct signals, it's not going to keep you asleep and you're going to wake up. And second thing I would say is if you're a type A personality at all, anywhere on that spectrum, if you're waking up in the middle of the night and can't turn your mind off, many times it's because of our high adrenaline state. Now, this happens to type B people too who are under high stress, but I see it more often in my type A's. And those individuals, their brain is bathed in adrenaline all day long. And then suddenly, magically, we act like it should be gone at night. It still has to get out of your body. And so finding ways to be more targeted, specifically in reducing that. One of the things I have found in my personal experience to be really helpful is pulsed EMF therapy. This is definitely fringe medicine. Do not go do this until you talk to your doctor, but it's in the alternative medicine space. And the idea behind it is that electromagnetic therapy at low doses can help our body reacclimate its electrons in certain positions. And if it's placebo, I'm totally cool saying that it's working on me. if it's real, I'm also game for that because there are studies that show different things work at different levels, but sometimes just doing that grounding activity can help. All right, hopefully I put some really crazy ideas out there to make you all think. And now we'll turn it over. Dr. McKean, do you want to go first and tell us a few tips you might have?
Well, in the sleep space, that's like one of the first things I talk about with patients because I tell them that like it's the rate limiting step. If you're not getting good sleep, it's going to be impossible for me to help you to get like mood and anxiety at like a good solid improvement in those areas. Now, I also tell them on the flip side of that is you could be getting great sleep, and that doesn't like 100% mean that everything's going to be perfect either. But I'll do silly things like look at their birth date or see what holiday's coming up, and I'm like, okay, like what needs a glow up in the bedroom, what needs an improvement, and like ask for that for your birthday or for a holiday or for Mother's Day or something like that. So yes, darkness in the room, but I talk about like light in the room, sound in the room, smell in the room, temperature in the room. Do you need a new pillow, different sheets, pajamas, sound machine, like anything to optimize sleep, because again, sleep is such a rate limiting step for improving everything. And then, talking through kind of like sleep apnea kind of symptoms. I can't believe how many people have even maybe had a sleep study and then they were like, yeah, I didn't really want to use that machine. And I'm like if you have sleep apnea, it's imperative that it be treated, and talking with them about, and I just like it's one of the areas of medicine that they are constantly like coming up with different ways because we know how important it is for you to get good quality sleep and improving upon that. So I talk about that, other like non-hormonal strategies, or non-medication strategies too. I talk about, psychotherapy in general. So like any of these things, any life stressors, any sort of situations that could be aggravating sleep, could be aggravating just your quality of life. Let's have you find somebody, even just that safe space, just to have that, whether it's a couple times a month, or if someone's looking more for like executive coaching, like kind of like moving them in that direction as well. Because if we're going to go the non-pharmacological route, because I get a lot of that too with being a psychiatrist and people being worried about the kinds of medications that I prescribe and potential side effects, I do have to have an armamentarium of non-pharmacological strategies as well. And as we are getting into, my least favorite time of the year, both personally and professionally, as the daylight hours are getting shorter and shorter and shorter until that magical day in December. I talk about bright light therapy and how important that can be. And that on my side of things, there are studies that have shown that it's equivalent to a low dose of Prozac when it comes to managing mood and anxiety.
Fascinating, isn't it? All the different things out there. Dr. Lynn, do you want to, from your perspective, share?
Sure. So first I want to say, Dr. McKean, there was many years ago, you gave grand rounds to the GYN department at SLU, and you talked about that bright light therapy. And I recommend that all the time. I see so much seasonal affective disorder. I have a child who goes to school in Scotland and he says it's dark all the time. I'm like, I have a thing for you. So he has one of those bright lights. I will say I see sleep problems all the time, and it is so important and so difficult sometimes to treat. I see many women who wake up and they can't fall back asleep because their mind is wandering and they're on fight or flight mode because they're stressed. So there are apps. I like the app CBTI. That you can download. It's sort of guided meditation, and there's different options. So, just have your AirPods by the bed. When you wake up, pop them in, and then you concentrate on that, and it draws your mind away from those other stressful thoughts so you can relax and fall asleep. Also recommend Calm app. I too will ask about sleep apnea because you'd be amazed how many times I see women are like, I can't sleep. And then I'm like, oh, well, I'm going to send you we tried all these things. You're not getting better. I'm going to send you to a sleep medicine doctor. And they say, oh, I already did that. And I have sleep apnea. I didn't want to wear my machine. I'm like, oh, wait, we got to treat that because low quality sleep, like we said, will affect everything. And I'm not a sleep apnea doctor, but I know that there are like newer ways to treat it that maybe aren't so cumbersome as the big CPAP machine. And then sometimes if we're trying to steer away from prescription medicines, I'll recommend magnesium. To take at night too.
Yeah.
But if someone really is truly having terrible insomnia, then I'll usually refer them to a sleep doctor.
Good points. And some of the new sexy changes in the sleep medicine world, they now have a mask that only covers your nose. and has a pivot at the top so that you can sleep on your side or on your stomach or whatever. The other thing is that a lot of people ask about the dental devices, and they're not covered by insurance, and they're a little bit of an investment, but the people who have them seem to love them compared to the insurance covered CPAP machines. But 100% agree with both of you that if we're not treating sleep apnea, we're setting people up for all sorts of problems. Keep in mind during sleep apnea, right, the oxygen comes down. If your oxygen level is low, how does that affect your metabolism? How does it affect your brain function in the next day? How does it affect your mood, right? So there's multiple ways this plays out. So definitely not ignoring sleep apnea is a wise thing to do. Dr. Lynn, when we think about integrative medicine, which is a lot of what my interest is in, I hear women really raising interesting points in the realm of gynecology, and I feel like these are gaining traction. And so I'm curious from your perspective, acupuncture, herbal remedies, even some of these laser rejuvenation things that can be done in the vagina. Like, where do we know what works, what doesn't work? How do we know not to waste our money? Just curious if you wanted to weigh in anywhere on that realm.
Sure. So let
Take
me
it
start
away.
with vaginal laser first. So vaginal laser, you have to be a little bit careful because a lot of the places that do vaginal laser will tell you it treats everything. It's just vaginal rejuvenation. It's going to fix the vagina. It's going to fix prolapse, incontinence. It's going to make the vagina tighter. And they sell it as going to treat everything. Well, there's not really a lot of published medical studies to prove that it actually works for everything. There is, I wouldn't say a huge amount, but a moderate amount of published medical studies looking at the vaginal laser to treat genitourinary syndrome of menopause, which is vaginal dryness due to lack of estrogen. Most of the small studies that don't have a placebo group show that it helps, right? When they just ask you how the vagina feels before they do the laser, ask you how it feels after, people will say they think it worked. But we don't know how much of that is a placebo effect. There are some larger studies with a placebo. I know there's one with a placebo that says that laser is equivalent to estrogen, but there are also placebo-controlled vaginal laser bigger trials that show that it doesn't do anything. And part of the problem with that is that there's so many different types of lasers, so many different types of settings. How often are you going to have this done? So we don't have a huge body of evidence saying, oh, yes, everyone should get the vaginal laser. Now, when you're treating genitourinary syndrome of menopause or vaginal dryness due to low estrogen, we know that estrogen works and it's incredibly low risk and it's covered by your insurance. Whereas vaginal laser is very expensive, not covered by insurance, and it doesn't have a lot of data to support its use. I don't think it's wrong. And there are some people, especially those with a prior history of breast cancer, who just will never go near a droplet of estrogen ever again. And do I think it's a reasonable option for them? I do. The chance, the risk of doing a vaginal laser in the right hands is very low. But the problem is you get these sort of med spas who are doing lasers, like you get somebody who's not a trained gynecologist who doesn't look in vaginas and doesn't know what is pathology and what is abnormal. So I would really, if you're one of those people who never want to go near estrogen, you're considering the laser, I would go to a physician, not a med spa. 100%. Someone who's used to looking in the vagina and knows what's normal and knows what's not. But if you're not afraid of estrogen, and I will say if you have breast cancer, there's never been a study shown that using low dose vaginal estrogen will increase the risk of breast cancer. So I feel very comfortable treating my breast cancer patients with low dose vaginal estrogen. There's 2 products on the market that have the lowest amount that's absorbed systemically, minimal, one of them not at all. But there are oncologists who get nervous about that, which I get it. Their job, they're afraid of estrogen, right? Especially if someone has an estrogen receptor. But even breast cancer patients can use low dose vaginal estrogen. And I already forgot the second question that you asked me.
Just within the scope of integrative gynecology. So does acupuncture have a role?
Yeah. So acupuncture, yeah. So it's the same thing. It's not a huge body of evidence that says that it's, everybody should be doing acupuncture, but there is some data on acupuncture and hot flashes. Some shows it helps, some shows it doesn't. But when you look at acupuncture, the risks are so small and it might work. And even if it's placebo and it fixed your hot flashes, or the other place I use it is for pelvic pain. There's so many women that suffer with chronic pelvic pain. They've tried everything known to man and nothing helps. There's a role for acupuncture in those patients. I believe in acupuncture. There's just not a whole large body of evidence to say, oh yes, this for sure works.
But lack of evidence does not mean harm. And that is something in our medical culture we've almost forgotten. And, all of us, as we went through medical school and residency, I imagine, are of the generation where everything was evidence-based medicine. If you can't have evidence for it, then we don't do it. Well, we're never going to have evidence that jumping out of an airplane without a parachute is a bad idea because no one's going to do that study, right? But we can all agree that common sense does have a role. So lack of evidence does not equal harm.
Yes.
Dr. McKean, as you're thinking through some of the integrative psychiatry that comes to mind, I imagine you're getting some concepts and patients that you're thinking through and saying, oh, that worked or that didn't work. Would you have anything that you would share with our audience in the perimenopausal years in that regard?
Well, back to the acupuncture, I definitely have a lot of folks that are trying that, again, concurrently with other management that we are doing, because again, as Dr. Lynn said, like low risk. So, when I have people come into my office and they're like, hey, how about I try this? How about I try that? And sometimes it's something like acupuncture. Sometimes it's a supplement or an herb that I haven't heard of. I am again, I'm not an expert in, and I haven't done training in integrative medicine, but I am happy to look into some of these things with them and look through it and see if I think that what the risk is. And if it's low risk, most of the time I am supportive of them trying it. Not necessarily in lieu of maybe treatment that they're already taking. I also have to talk with them about, again, when we were talking about sexual side effects and antidepressants. Unfortunately, for some, it's not an option to completely taper off of those medications. So it's kind of what can we do to be supportive? And if it's a libido issue, for instance, a libido can have a lot of reasons. And so I'm like, can you still orgasm? And we kind of go with what are the positives that are still having? I'm like, oh yeah, I can totally still orgasm. I'm like, okay, well then we're going to work on the libido. So, a lot of my conversations with folks are, let's keep doing the things that we know that are evidence-based, but supportive of non-evidence-based things as long as it's not risky. Because that comes up in with a lot of my pregnant patients too. A lot of they're told is well, that hasn't been studied, so you shouldn't take it in pregnancy. And I'm like, but if it's been around for 40 years and there's also nothing that shows that it's harmful, then perhaps it's okay to continue doing that as well, versus the things that I do know, which is if you stop your medication completely, that's going to be really, really risky.
Yeah.
So I have a lot of people, again, for sleep, for anxiety, even for mood, they want to try some other things. And again, as long as I find them non-risky, and not going to work against them, I'm supportive of it. And a lot of times I've learned some new things. So
yeah, that's a great way to dive into it and approach. I had a conversation with a patient yesterday who I do work with a lot of supplements. I don't think all supplements are poison. I also don't think all supplements are helpful, but there is a specific one I do quite a bit with because of metabolic health, and that's berberine. And this particular patient had reached out because they didn't have the normal indications we would use berberine for: insulin resistance, fatty liver, some type of metabolic abnormality. What they did have was those atherosclerotic plaques that Dr. Lynn was talking about earlier in the coronary CT. And this individual had done some digging and found that maybe berberine was good for that. And they'd sent me the study and it was in hamsters. And I was like, okay, we're not going to apply hamster medicine to people medicine. But what it did was allow me to look at that question specifically and take a broader research. And I actually found some interesting studies where it has been studied in atherosclerosis and how it does impact the lipid profile. And so it helps, I think, to be educated when you see these things and when you have questions. If somebody's blowing you off, don't take no for an answer if there's really something there. And that's always the hard part because most physicians have 12 minutes with you. So it's really hard to know how do you do this. You can't flood their inbox with all the different research you're finding because they will completely not be able to handle that. If you think that the average primary care doctor, for example, has 3,000 patients, if they're getting a lot of messages they can't respond, they won't respond. So I encourage you, if you're finding things on, especially in the supplement world around a specific problem that you're running into, is to send the link for that article to your person and then schedule an appointment a week or two later and say, I just want to talk about this article. We don't have to make any decisions that day, but I'd like to hear your perspective on it. Because unfortunately, we've set our system up in a way that you can't have decisions made often in 12 minutes. It has to be a continuity and a longitudinal discussion. That's where you can advocate for yourself, though. And the more you can research and go into these conversations, I think in all of our specialties, gives everyone the opportunity to have their best health, which is what we all want, right? We all want to have our better health. And yes, we do see men as well as women in our practice. So I think I'm going to invite both of my colleagues here. While we're finishing up, we have a few more minutes. Would you mind dropping your social links in the chat? So if you're on Instagram or TikTok or anywhere that folks can find you and follow you. And while you're doing that, I'm going to pivot to one more question. This is around chronic stress. And I'm curious, from all of the different realms, the different perspectives that we hold, chronic stress is not going away. It's getting worse, it seems. We are fortunate to have this discussion today in a very fun time of year and in an election year. So I know everyone's stress is high. And I'm curious, what would you say to our listeners? What's the one thing that you see chronic stress impacting in your specialty? For me, it's heart disease. I see chronic stress is underappreciated in the role it plays toward heart disease. And the classic person is the high type A personality who has a heart attack at 55 because they never treated their stress. But so many of us live with chronic stress. So how does that show up in your practice? And what's your tip for somebody in dealing with that? So either of you want to go first? That was a long question, but hopefully you can be creative with it.
So I think chronic stress, I feel like the way that our traditional healthcare system is set up is you don't like if you have 12 minutes, you don't have time to really discuss those things. You got to get your PEP done or whatever. And so, one of the benefits of a concierge practice is we have time to spend with our patients. And I think it's important to discuss stressors and that here are some of the things that you can do to lower your stress. Some things you can't change, but there are things that you can do. So let's sit down and figure out what can we do to take care of ourselves. And what I find, you talk about the perimenopause and menopause, this sandwich generation where maybe their kids are leaving, they're having some empty nest syndrome. They maybe have aging parents that now they have to take care of, which can be highly stressful. And women take care of ourselves last. Right? Like we got to take care of the kids, you got to take care of the parents, you got to take care of your partner, and we put ourselves on the bottom. And I think that one of the things that I like to discuss is that you have to take care of you before you can take care of everybody else, right? Put your own mask on before you put on your others, and giving women permission to do things for themselves. And everybody responds to stress differently, but maybe go get a massage. Get a facial, do acupuncture, do pranic healing or Reiki. We do that in our office, which I love because it's a low risk option. And there's so many women that are really suffering with stress that don't want like a medicine for their moods or things like that. And I see it a lot because the perimenopause and menopause time is the sandwich generation that's dealing with a lot of issues with growing kids and aging parents. So that's kind of what I do.
Yeah, very helpful. Thank you. Dr. McKean?
Sure. So yeah, this is pretty much all I do every day. So I talk about realistic expectations because I do have a lot of women who see me who are very successful women, and that might be professionally, personally, whatever it is, but they have done really well for themselves and they've prided themselves on being very productive and efficient and all of these things. And so we kind of talk through like all the different things that they've added in their life, like maybe since they were 25, that might be impacting quality of life. And so I say, like, if you think you can do all of those things, I'm like, there's a bunch of work-life balance, essentially BS out there. Like, let's just be frank. Like, You know, there's going to be times that like work's going to have to take a priority, and there's going to be times that like personal life has to take a priority. And there's nobody who has mastered this work-life balance, even if they want to sell you a program that's going to tell you how you're going to perfect it. And I often use the analogy of like either like juggling or like spinning plates. And instead of thinking that like every single thing is like a breakable plate or a breakable ball, I say like you've got a couple professional ones and a couple personal ones that maybe are breakable, and everything else is not. And sometimes if you're spinning all the way and you're going around or you're juggling, you're going to drop some. So you might miss the assembly, or you might like not meet the deadline. And most of it's going to bounce, and it's going to be okay, because you're going to have enlisted your support system, and you're going to have someone else taped that assembly for you, or you're going to be like, hey, I'm human, I missed the deadline, but hey, I got it done in like 2 days later. So you're going to ask for forgiveness, and like, and know that you can't necessarily do it all. And some women don't want to hear that. But again, I have them set realistic expectations, because I do kind of like point out to them, like, you have kids, you have this relationship, you have this job, you have your parents, you have financial stressors, you have your own health issues. But if they have chronic stress, they're not getting that good sleep. So I make them come back to all these core things. We need to optimize your sleep. We need to make sure that you're about your nutrition, that you're staying hydrated, that you're avoiding substances, because a lot of them start leaning a little bit more on alcohol. Or now that cannabis is legal, you know, I can't tell you how many times I screen for substance use. And then like 30 minutes later, there's the, oh, I take a cannabis gummy every night. Like, well, that still counted when I was asking you about those things. So, you know, I see stress lead to like a slippery slope of like behaviors that then just kind of compound on it, because people think like it has to be perfect. And I just try to tell them like, no, it doesn't have to be. And at this phase in your life, you may have to say some no's. You may have to downsize some things. And what are the core things that have to happen on a given day or in a given week? And let's kind of help you to do that. But if your expectation is that everything's going to be perfect, well, then we need to regroup. We need to pivot.
Yeah. And what I heard both of you say, and I would fully support, is you have to be intentional, because life will happen to you if you don't stop it. And if you are going to let it just wash over you, then that's a decision too. Being passive is a decision. So what a fantastic close to a great conversation. I am so glad we were able to connect again today. As we close, is there any last minute thoughts that you want to share with our audience, Dr. Lynn?
I think my only last minute thought is, you know, like I said, that if you're not feeling good in your perimenopause and menopausal area, don't let anybody tell you, oh, you're just getting older. Oh, it's normal. No, no, no. There's plenty you can do to feel like yourself again.
Absolutely. Dr. McKean?
Just wanted to highlight to everybody, it is World Menopause Month also. It's breast cancer awareness, but it's also World Menopause Month. World Menopause Day is the 18th. So there's going to be a lot of really good information out there. I know all three of us will be sharing these things again on our social media platforms, but there are some good other platforms out there that provide a lot of really good information. So
Absolutely.
thanks for joining us.
Absolutely.
Thank you all for
Thank
coming.
you. We are filled with gratitude that you took the time to be here with us today. We'll be posting on our social profiles for our next, we're trying to do this once a month. So we will post again. Hopefully we will connect with each of you. Look forward to each of you continuing in your health to improve and to be the person that you were created to be. Many thanks, much gratitude, and have a wonderful day. Bye.